Good afternoon, everyone. We are delighted that you could join us today. The title of today's webinar is Overcoming Barriers to Shared Decision-Making. This webinar is sponsored by the Agency for Healthcare Research and Quality. Again, my name is Rebecca Burkholder, and it is my pleasure to serve as the moderator for today's presentations. For the last 2.5 years, I've had the opportunity to serve as a member of the technical expert panel associated with this AHRQ program. I know in my work as a consumer advocate and on this expert panel that this is a very important and timely topic, and I look forward to today's presentations. We are pleased to have with us today an esteemed group of presenters, including Dr. Franz Lagar from Laval University in Quebec, Canada, Dr. Mark Friedberg from the RAND Corporation, and Dr. Elena Fournier from AHRQ. This webinar event is accredited by the Professional Education Services Group. And for those of you who are interested in receiving continuing education credit for participating in this activity today, information about how to claim your credit will be presented at the end of the presentations and will also be emailed to you after this webinar. Lastly, I want to note that neither the presenters nor the sponsors of this event have any financial interest to disclose, and no commercial support was received for development of this learning activity. The learning objectives for today's webinar are that participants at the conclusion of this webinar will be able to do the following. First, identify key barriers to shared decision-making from both the patient and the provider perspectives. 2, to describe some of the strategies for overcoming barriers to implementing shared decision-making. And 3, to be able to describe AHRQ's evidence-based initiative to promote shared decision-making through its SHARE approach, and how this program was developed to address some of the common barriers to shared decision-making. And now for our first presentation by Dr. Lagar. Franz Lagar has been a family physician in Quebec City since 1990. Dr. Lagar is full professor with the Department of Family Medicine and Emergency Medicine at University Laval in Quebec City and Canada Research Chair in Implementation of Shared Decision-Making in Primary Care. Dr. Lagar has authored 262 peer-reviewed publications, and she has led major research initiatives on the topic of shared decision-making in primary care. She is also the scientific director of the Laval University Primary Care Practice-Based Research Network dedicated to shared decision-making. Dr. Lagar, I'm now going to pass this presentation over to you.
Yes, hello everyone. I'm very happy to be with you today. And first, before beginning, I'd like to dedicate my presentation to Dr. David Sackett, an American-Canadian medical doctor born in the US who had moved to Canada to open up the first clinical epidemiology department at McMaster and a pioneer of evidence-based medicine. So I just want to pay my respect to him and thank him for inspiring many of us in serving our population with the best evidence. I have no relevant financial relationship to disclose. Learning objectives that I will be focusing on are identifying key barriers to shared decision-making from the patient perspective, as well as describe strategies for overcoming barriers to implementing shared decision-making from the patient perspective. Briefly, I will define shared decision-making, the way our team operationalizes it in our work. I will also review some of the barriers to shared decision-making from the patient perspective. But since shared decision-making is a relational process, I will also refer to some of the barriers to shared decision-making that are common to both patients and providers, and finalize this piece of my presentation on effective strategy for addressing barriers to shared decision-making. So first, briefly, shared decision-making is foremost an interpersonal and interdependent process. So it's a process between at least two people or more, and it's interdependent because it is expected that people that are involved in sharing decision together will influence each other. It recognizes that the decision is required. It highlights the best available evidence about risk and benefits of each option, and it takes into account the provider guidance as well as the patient values and preferences, and this is patient-specific. It's known that most of the time, providers and healthcare teams will say to you when you try to implement shared decision-making that they already do it. However, this is a systemic review that our team has performed with First Hotel Nicolas Couet that have shown that across 33 studies, it's obvious that it is not happening. The mean score is about 23%, from a range of 0, not happening at all, to 100% being there. So what are the barriers for shared decision-making not happening, and especially those that are perceived by patients? This is a sneak review by Nathalie Joseph-William and the group with Dr. Glenn Elwin, now at Dartmouth, who have reviewed studies that have assessed in patients their perception of what would impair the implementation of shared decision-making. They reviewed a total of 44 studies, and they intuitively came with this taxonomy of barriers to shared decision-making in clinical practice. So overwhelmingly, you have the barriers at the healthcare system and organization level that are perceived from the patient perspective, as well as those that are at the level of the interaction. So please remember, shared decision-making is a process, and it's an interpersonal and interdependent process. Briefly, at the level of the healthcare system and organizational level, you have time constraints, problems with clinical pathways, the way that the flow of the work is happening, problems with continuity of care, especially in primary care where you have teams of providers, different providers providing care, and also characteristic of the healthcare setting such as lack of privacy. And you have, at the level of the encountered and the individual, barriers that are perceived such as knowledge and power. And the boiled down message, or the main message, is it's not that individuals do not want to participate to share decision-making with their provider, but they need support and they need for provider to raise their self-efficacy. Now that we've looked at this very briefly, we've also looked at barriers from the provider perspective years ago, because since this is happening at the clinical level, you need to pay attention to the relationship between the patient and the provider. And what we found out were similar barriers that were experienced at the level of the provider, such as those relating to knowledge, not knowing what's shared decision-making, attitude, not knowing what would be the outcome if they were to implement shared decision-making, and lack of efficacy, and so on. Interestingly, aligned with the Joseph-William Systemic Review, this is another of our work that we've done where we've asked 110 pregnant women to tell us their intention to share decision with their provider. And we saw that not only factors at the level of the patient were involved, but the physician attitude was also influencing the woman's intention to share decision with their provider. So now if we look and try to integrate this into the relationship, and we again rely on the Joseph-William taxonomy of barrier, we see with all the red circle that some of those barriers are actually common to both providers and patients, such as time constraints, the characteristic of the decision, some type of decision may be felt not to be prone to shared decision-making, patient characteristic. Also, our most vulnerable population may not be actually felt that they could share decision with their provider or even want to do so. The expectation, outcome expectation, and so on. So the main message here is, as though you have barriers from the provider perspective and you have barriers that are specific from the patient perspective, you also have to pay attention to those who are actually similar and common, because this may be a key area to intervene. So before intervening, and that actually is one of the key aspects that may be an intervention, is to try to debunk some of those barriers because they're myths. So there is this whole idea from the patient and the provider perspective that it takes too much time. But when you look at the Cochrane Cystic Review from Dawn Stacy and colleagues, 9 trials of implementation of decision aid that had assessed actually if patient had engaged in shared decision making or not, showed that in terms of time, there was no difference in 7 of those trials. 1 was longer and 1 was shorter. The one that was longer was actually happening in palliative care. So one of the message now of this Cochrane review is that we do not have robust evidence that, in fact, trying to engage patient in sharing decision with their provider takes much longer. There is also the myth that not everyone wants this, especially some of our most vulnerable populations, since some of our providers hear from these people, what would you do if you were in my situation? But multiple cystic review, some of them who have actually shown the historical trend, remind us that actually more and more patients want to be involved in shared decision making. And that in fact, we need to be very careful about this idea of some of our most vulnerable population perhaps not feeling self-efficient efficacy or having enough self-efficacy to share decision, because if we do rely on some of their perception that they may not be fit to do this, we will perhaps just increase inequities in participation in decision-making and in health. So we need to be careful. Not everyone can do this. It's always important when we try to teach and train patients or provider or people of our societies that in fact you can translate what you'd like them to train into. If you can translate this into specific behavior and cut it down in smaller pieces and actually think about this like learning to ski here, if you're here in Canada, especially, but you can train them to learn specific behavior. And Makul and Clément, with their cystic review of shared decision-making concept, proposed to us a list of essential specific behavior that can help you translate to patients that they, in fact, are able to gain self-efficacy to train into those specific behavior. Now, what can be done to address barriers to shared decision-making as perceived by patient and as you will have understood by the dyad, by the patient and the provider? This is where our team invests most of its energy, is to review what's effective in implementing shared decision-making in clinical practice. And this is the update of our Cochrane review published last fall. And 2 main messages is if you wait for this to happen by itself, you're going to have less efficacy than if you are proactive and actually implement it with the implementation intervention that is well thought about at re-arrive. But also that an implementation intervention targeting both patient and provider seems to be much superior to implementation of intervention that solely focus on one or the other. So again, emphasizing that shared decision-making is a process that is interpersonal and interdependent. So it would make sense that if you target both or all who are involved in the decision-making process, you would achieve more than just targeting one. So let's look now at what works. So patient decision aid, yes, they mostly target patients, but by themselves, not only do they raise knowledge, but they tend to also get patients to be much more active in the decision-making process. And this, again, is drawn from the Dawn Stacy Cochrane review of 115 trials of decision aid we published last year. But patient decision aid may not be enough. This is here a study by Dr. Collins at Dartmouth, who did a longitudinal study where at baseline they did assess in patient how comfortable they were with the decision, so it's called decision conflict, and then reassess decision conflict after the use of a decision aid, but again reassess it again after they had met with their provider and discussed their decision. And you see that each time that they've moved into this longitudinal trial, that if you combine decision aid with counseling, coaching, you will achieve more in terms of reducing decisional conflict by actually raising their knowledge of the options and also improving the match between what's important for them and their choice. Also, public campaign may raise awareness and also seems to be effective. This is drawn from a study in Australia, and it's been done also in the UK, where if you prompt the public or patient to be with a question that they can ask to their provider, you will actually achieve more decision making during the consultation than obviously if it's a control group and they're not prompted. So not only decision aid will be effective, but you could also envision prompting patients with questions when they meet with their provider. And training of provider, I will let my colleague Mark discuss this a little bit more with you, but obviously training of provider. So again, as we saw in the Joseph Williams review and some of the work we've done, you need to modify their attitude, and they also need by themselves to learn new behavior so they can share decisions with their patient. So this is out of some of the work we've done here in Canada to train providers in sharing decisions for antibiotic use for a upper respiratory tract infection. And we did train them. We combined the training with the patient decision aid, and we showed, this is the figure out of the publication, that patients, after meeting with one of the providers that had been trained and had been tooled with the decision aid to discuss this decision with their patient, reported being much more active in the decision to use antibiotic or not than those that had been exposed to a provider that had not been trained and had not actually been receiving a decision aid. So you can and you should be thinking of training your provider so they don't meet patients that are prompt and they don't have then the needed competency to answer properly to these patients. Key message. So to fully reach patient-centered care, patients need support to participate in decision making. This is a learnable competency. Decision making is a process whereby patients are supported to make decisions, and what we at this point know may be effective in increasing decision making in clinical practice includes patient decision aid, counseling, decision coaching, public awareness campaign directly to the public or our patient, training of health professionals, and please remember that targeting both patients and provider is needed. Thank you very much.
Thank you, Dr. Lagar. And now I'll be introducing Dr. Mark Friedberg. And Mark Friedberg is a senior natural scientist at the RAND Corporation, the practice lead in payment models and healthcare delivery for RAND Health Advisory Services, and a practicing general internist. His research focuses on performance improvement by healthcare providers, innovations in primary care, and methods for measuring health system quality and efficiency. Dr. Friedberg has developed and fielded surveys of patients, physicians, medical group leaders, and other clinical staff. His clinical work has included ambulatory, primary care, and hospital-based internal medicine, and he is an assistant professor of medicine, part-time at Brigham and Women's Hospital and Harvard Medical School. Dr. Friedberg.
Thank you very much, Rebecca. I'd like to thank the AHRQ and the conveners and my co-panelists today. I'm going to be talking about some strategies for overcoming barriers to shared decision-making from the primary care provider perspective based on a study that we evaluated on behalf of the Informed Medical Decisions Foundation a few years ago. They don't have any financial relationships to disclose. And learning objectives today are first to identify key barriers to this shared decision-making from the provider's perspective, and to describe some strategies for overcoming those barriers to implementing shared decision-making. So we evaluated a demonstration of shared decision-making, and this was conducted, as I said earlier, by the Informed Medical Decisions Foundation in 8 sites containing approximately 34 primary care clinics, and these were scattered around the United States. The sites were selected for prior quality improvement experience, and some had, but some also did not have prior decision aid experience. The demonstration was conducted from July of 2009 to June of 2012. And in addition to being sponsored by the Informed Medical Decisions Foundation, there are a few specific inputs to the participating practices. First, there were some free decision aids, and these were the decision aids that were published and maintained by the foundation. And these were for a wide variety of different conditions. The sites also received some technical assistance to help them use the decision aids to conduct shared decision-making, and the sites participated in a learning collaborative with monthly conference calls. We performed a qualitative evaluation of this demonstration at 18 months, so right at the midpoint. Our objectives were to identify barriers and facilitators to implementing shared decision-making in the primary care settings that were participating in this trial, and also to develop some options for evaluating and measuring shared decision-making performance going forward. Here are our methods. We used semi-structured interviews with 23 leaders and clinicians from all demonstration sites. We also included 10 patients from one site who had each received a decision aid during the demonstration. And our interview protocols investigated facilitators and barriers to engaging clinicians and integrating decision aids into key operational tasks within these primary care practices. We analyzed interview responses inductively for recurrent themes and matched them to a conceptual framework that we also developed as part of this project. So here's a logic model that we developed both from talking to foundation leaders and also to the site representatives that we interviewed. The key steps of shared decision-making based on decision aids in the primary care setting. And I'll just work from left to right. First, there's decision opportunity identification. So this is a realization that there is a decision to be made and to which a decision aid corresponds. The second step is using the decision aid. In this step, the decision aid is distributed to the patient. Usually there's some kind of coaching or description around that on how to use it. And then, of course, hopefully the patient will then use the decision aid. The third step is the post-decision aid conversation. At this time, the patient has used the decision aid already, and this conversation is, again, with usually the primary care provider, but it could be somebody else in that office, or it could be a different kind of provider. And the purpose of this conversation is to clarify medical information contained in the decision aid to make sure the patient was able to understand the information and the decision aid gave them what they needed to be able to make that decision. Also, to elicit values and preferences of the patient, and really this is the provider's opportunity to learn from the patient to make sure that he or she does understand those values and preferences, and then to actually make the shared decision. And of course, this doesn't necessarily have to happen at once. This post-decision aid conversation is very simplified in this diagram, but it certainly could occur over time. The decision can be revisited. There may be many parties involved in that decision, including family and caregivers. And then the last step is the delivery of health care. And ideally, this would be care that is consistent with that final shared decision. So here were some barriers to shared decision-making that we uncovered. First, overworked physicians generally did not recognize decision opportunities and distribute decision aids reliably. And some site leaders expressed to us that when they relied on physicians to trigger the distribution of decision aids, so basically in that previous slide, that first step is really relying on physicians to both recognize the decision opportunity and then also distribute the decision aid. These site leaders estimated that only about 10 to 30% of patients facing decision opportunities received the corresponding decision aids. And here's a quote, or actually a set of quotes illustrating this point. The first is, as long as you have physicians in the middle of distributing decision aids, they have too many other things on their plate to reliably ensure this would happen every time in a 10 to 15-minute appointment. Next quote is, we hear physicians say, I seem to be the problem here. How do I get myself out of the loop so I can get the decision aids to patients that need to get them? And the last one is, in the real world, I'm not sure we can expect the physicians to identify the patients for decision aids. The next barrier we uncovered was insufficient provider training. This stemmed from an understanding that the site leaders relayed to us that recognizing decision opportunities and having post-decision aid conversations are skills that providers must learn. And here's an example quote. We found that physicians felt that they were already doing shared decision-making before we introduced the decision aids. To me, it's not really shared decision-making when there's only a 15-minute appointment and patients can't really engage in a conversation when they don't know much about the topic. Another quote illustrating the same point was, you really have to pay attention to the clinicians in this equation. You can't just ask them to do something and assume they'll know what you mean. And we underattended the training of our clinicians. Another key barrier was in the adequacy of clinical information systems and how well they match to shared decision-making. So for one thing, none of the EHRs for the sites that were using EHRs, and I believe that was the majority of them in this study, were able to track the full sequence of steps involved in shared decision-making. So some key examples were that they were unable to flag patients as candidates for decision aids or indicate which patients received them. A couple of sites were able to do that function, but the remainder were not. In addition, they lacked mechanisms for communicating patient-reported values and preferences back to providers. And there were no longitudinal functions to track patients through the shared decision-making process, including determining whether patients had timely post-decision aid conversations with providers, and furthermore, whether they received care that was consistent with their shared decisions when those were made. Here's an example of the clinical information systems not being able to integrate with decision aids. So many of the decision aids actually would have a questionnaire that patients could fill out. And the idea there was to be able to not only help the patient think through their values and preferences, but also to communicate that back to the provider. So here's a quote illustrating an issue with that, which was that all of the information from the decision aid questionnaires is off the chart. There is documentation that a decision aid was given, but anything from the surveys is kept completely separate. So I'm going to shift now over to some solutions that the sites employed to address some of these barriers. The first one was automatic triggers for decision aid distribution. So this was especially useful for screening decision aids, for example, for cancer screening tests. So they could trigger distribution on patient age and gender. So here's a site leader describing how this was done. The more automatic you can make it, the more successful decision aids can be in primary care, whether it's having the health technician prescribe it or having it be an automatic mailing based on the visit type. Anything you can do to streamline the process and not rely on clinicians' memory to include the decision aid as part of a visit routine will be a successful strategy. And I should note that in many cases, one advantage to doing it this way was that the decision aid could be distributed before the upcoming next primary care visit. And that would create an opportunity for that post-decision aid conversation to occur during that already scheduled visit. Another kind of trigger was to trigger on specialist referrals for surgical procedures in particular. And the idea here was that the relative greater focus of specialist visits may facilitate a more reliable performance of post-decision aid conversations. And one site leader was able to express this. In the specialty clinic, the decision aids are much more frequently discussed. It's a bigger challenge for the primary care practice because there may be several things a patient wants to discuss, but when you see a specialist, you see the doctor for a particular purpose. So this not only facilitated the distribution of the decision aid, but also the performance of the post-decision aid conversation at the initial consultation with the surgical specialist. Another strategy was to engage team members other than physicians. And an example of this would be a decision coach to introduce the decision aid. Here's a patient explaining how this worked. When you're with the doctor, you don't get a chance to ask a lot of questions. A nurse I had never met before came in and introduced me to the decision aid. She had a CD and a book about the surgery, and of course I was interested in that. So this was pretty well received by the majority of the patients that we interviewed from one site that was doing this. I'm going to shift gears again a little bit to measuring the successfulness of implementing shared decision making. And this could be useful to folks who are trying some of these solutions out, or maybe have or have not encountered some of these barriers, and they just want to see how well the entire process is working. Based on our conceptual framework, we believe that process measures should capture all steps of shared decision making. And in fact, an all or none measure may be appropriate. The key point here is that even if a decision aid is prescribed and used, poor or non-performance of the post-decision aid conversation can completely undermine shared decision-making. And there was a sobering story described by Lin et al. In Archives of Internal Medicine in 2012, and it's called The Consequences of Not Respecting Patient Preferences for Colorectal Cancer Screening, an Opportunity Lost. This was a situation where a decision aid was used, and then the post-decision aid conversation was performed so poorly that the patient's preference was overruled. So we believe there may be some vulnerabilities in these later steps of shared decision-making that may be some good targets for measurement once you've sort of gotten your process to a reasonable point on identifying decision opportunities and getting patients to use decision aids. Also, there are measures of decision quality. A number of people have developed these, including Dr. Lagar and also Karen Sapucha at Mass General Hospital. And the idea here is, in the end, was care consistent with the patient's values and preferences. Of course, this is what we all want to have happen, and if you're able to measure that before and after you've instituted a shared decision-making program, hopefully we'll be able to observe an improvement in those kinds of measures of decision quality. There are also indirect measures of shared decision-making performance. So I'll explain what this is. In theory, shared decision-making should produce variability that is driven entirely by patients and not providers. So, for example, if each provider in an organization has a PSA screening rate of either 100% or 0%, then the organization is unlikely to have implemented shared decision-making successfully, because what this would mean is that whether or not a given patient who is eligible for PSA testing receives it depends completely on the provider to which he or she goes, or he goes in this case. In terms of implications, achieving shared decision-making will probably require new operating systems for primary care practices. Major investments may be needed to develop and improve educational, operational, and informatics systems, and payment reform may be necessary. An undercutting theme an underlying theme, I should say, of many of the barriers we encountered was the sense that there was pressure on physicians to do a lot of things in a short period of time in the primary care setting, and a lot of this was potentially driven by fee-for-service payment. To the extent that alternative payment models can be adopted, some of that pressure may be relieved, and also investment in some of these other systems may be possible. There are no data yet on the successfulness of shared decision-making in medical home implementations. This is a question that's often asked. I sort of liken this to the quadruple axle of primary care. If you can do shared decision-making well, it implies that many other capabilities are present and functioning, including the ability to track patients longitudinally over time through a relatively complex process. Given the degree of difficulty, I think it's natural to expect some disappointments as practices figure out how to do this. That doesn't mean certainly doesn't mean it's impossible or that it's unworthy as a goal, but I think it certainly speaks to the challenges ahead of us. And I would say watch the measures in this space. Distributing decision aids is unlikely to be sufficient to guarantee that shared decision-making has occurred, and it's good to have some measures that go beyond distributing decision aids. And a key issue for policymakers here is just how high to set the bar for deciding what counts as engagement in shared decision-making. Some new payment models actually require engagement in shared decision-making, but exactly what that means is going to be up to folks who end up implementing those policies. A lower bar would be count for a rate of just distributing shared decision aids. A higher bar would be an all or none process measure, including all steps of shared decision-making, or some of those decision quality measures I alluded to earlier. Thank you very much for listening to my presentation. I'd like to turn it over to Elena now.
Thank you, Dr. Friedberg. Our last presenter today is Dr. Elena Fournier. Dr. Fournier is a health communication specialist in AHRQ's Office of Communications and Knowledge Transfer. In this capacity, she serves as a project officer for AHRQ's Educating the Educators project, a knowledge transfer project to develop the SHARE approach to integrating patient-centered outcomes research in shared decision-making. Dr. Fournier also works on other knowledge transfer projects to encourage use of AHRQ's research in practice. Elena has worked at AHRQ in various roles since 2006, supporting the effective healthcare program and the agency's work related to patient-centered outcomes research. Dr. Fournier received her doctorate in pharmacology from the University of Pennsylvania School of Medicine and her Bachelor's of Science degree from Trinity University in San Antonio, Texas. Dr. Fournier, we now turn the presentation over to you.
Thank you very much, and good afternoon, everyone. Thank you all for joining us today. Before I get started, I would like to thank Dr. Lagar and Dr. Friedberg for sharing their work with us today and helping us continue this conversation around shared decision-making. So we've heard a good bit of information on the barriers surrounding the implementation of shared decision-making in practice, both from the patient perspective and the provider perspective. With the increased emphasis that has been placed on incorporating patients' values and informed preferences within the clinical decision-making process through strategies like shared decision-making, we're beginning to learn more and more about what the barriers are to doing this and the things that are needed to begin to remove some of those barriers. One approach to addressing known barriers that has been cited in the literature and here in the webinar today is the development of training for health professionals to help them learn how to do shared decision-making. So that's what I'm going to be talking about for the next 15 minutes. So today I'm going to tell you a little bit more about AHRQ's efforts to develop a training program for health professionals on engaging patients in shared decision-making and using evidence-based patient-centered outcomes research tools to facilitate the process using what we call the SHARE approach, and more specifically to talk about how the program was designed to help address the known barriers to shared decision-making. So I have no relevant financial relationships to disclose. So many of you are already very familiar with AHRQ, or the Agency for Healthcare Research and Quality. But if not, I'll give you a little primer. AHRQ is a federal agency that is part of the U.S. Department of Health and Human Services, and our mission is to produce and disseminate evidence to make healthcare safer, of higher quality, more accessible, equitable, and affordable. And one way in which AHRQ strives to improve the quality of healthcare is through the synthesis and dissemination of patient-centered outcomes research, or PCOR, as we like to call it, and as mandated by the Affordable Care Act. PCOR is a type of comparative research that assesses the effectiveness of various healthcare interventions. It can be applied to study the comparative effectiveness of numerous interventions, including preventive, diagnostic, therapeutic, and palliative interventions, as well as healthcare delivery system interventions. PCOR compares the benefits and harms of these interventions and aims to find out how well interventions work in everyday practice settings, not just in clinical trials. So ideally, PCOR looks at the effectiveness of interventions, considering variables that are not always tested in clinical trials. These variables may include patients who have multiple conditions, are older, or are a different gender than those included in clinical trials. And as you know, these types of variables can affect how well a treatment works. Importantly, PCOR focuses on outcomes that matter to patients, like quality of life or being pain-free. So for the last decade, the Effective Healthcare Program has been AHRQ's home for PCOR, or often referred to as comparative effectiveness research. A primary goal of AHRQ's Effective Healthcare Program is to improve healthcare quality and patient health outcomes through informed decision-making by patients, providers, and policymakers. Effective healthcare program activities include evidence synthesis, or conducting systematic reviews of existing evidence to compare effectiveness of treatments or other types of interventions, and identifying relevant knowledge gaps. The Effective Healthcare Program also translates PCOR findings into plain language resources and tools that can help inform healthcare decisions that patients, providers, and policymakers have to make. These decision support resources compare the available evidence on the effectiveness, benefits, and harms of different treatments and interventions for specific healthcare conditions. And in the clinical setting, the primary purpose of these is to support shared decision-making between providers and patients. We have products that are available online for viewing or in print and PDF, or accessible on mobile devices and smartphones. And they're also available to order print copies for little or no cost at AHRQ's Publication Clearinghouse. Many of our consumer products are available in both English and Spanish. So you can find out more information about the Effective Healthcare Program and our resources at www.effectivehealthcare.arq.gov. So AHRQ also ensures the tools and resources get into the hands of people who need them through a variety of dissemination and implementation activities. And one of our efforts to disseminate and implement PCOR has been a knowledge transfer project called Educating the Educators, which was launched in early 2013. The project has aimed to train health professionals to use PCOR decision support resources in shared decision-making. The goal at the outset of the project was to develop an accredited train-the-trainer workshop and a collection of reference resources to support healthcare professionals in implementing shared decision-making. We planned on hosting 10 in-person workshops a year in varied locations across the country to train individuals who would then further disseminate the training to their colleagues and other health professionals. We've also planned to support the participants with ongoing webinars such as this one, providing technical assistance and a learning network of trainees who can then come together virtually to share their experiences and learn from one another. After 6 months of research and a year of development, the primary product of the Educating the Educator project was the development of an accredited training program for health professionals called the SHARE approach. So before I get too far down the line in telling you about the SHARE approach, I'm going to tell you a little bit about how we got to that point. And so for the first 6 months of our project, it consisted of a comprehensive collection of formative research, including a literature review and a health educator needs assessment to ensure that our workshop would meet the needs of health professionals. The health educator's needs assessment consisted of a broad-reaching web-based survey with 7 focus groups with health professionals from multiple health disciplines and key informant interviews. And the objective of the formative research was to compile information on current methods and best practices for conducting shared decision-making, key competencies that are required to perform shared decision-making, and the roles of different healthcare disciplines in shared decision-making, as well as barriers and facilitators for health professionals and patients, and what training approaches would be the most effective. So the ultimate aim of the research was to inform the development of our Train the Trainer program. And let me Please note here that in order to expedite the formative research and development process, we use something called the OMB Fast Track Clearance process for our data collection. This is a type of government clearance process that's generally used for government-sponsored data collections to inform product development and to gather customer feedback. So under this type of clearance, we're unable to formally publish our data, but I can generally discuss what we learned and how this formative research process informed our project. So for the purpose of today's discussion, I'm going to focus on some of the key barriers that were identified during that formative research phase and how the Share Approach workshop training has aimed to mitigate those barriers. So not surprisingly, and consistent with the barriers commonly cited in numerous other studies, we found that time constraints were seen as the biggest barrier by providers to implementing shared decision-making in practice. Another common barrier that was identified in the literature is the perception among healthcare professionals that we're already doing shared decision-making, so there's no need to change how we interact with patients. Across all of the mechanisms that we used when conducting the formative research for the project, we observed that many health professionals think that shared decision-making is either not applicable to their particular clinical scenarios and or that it is not possible with their particular patient population. So that is, their patients don't want to be engaged or can't effectively participate in shared decision-making. Other barriers included lack of organizational support and limited availability of decision aids. Most of the information regarding patient barriers for shared decision-making during the formative research phase of this project was based on available literature, as our health educator needs assessment did not directly engage patients and or consumers of healthcare. However, what we identified as the primary barriers for patients in the literature was supported by health professionals' perceptions of patient barriers in the survey and in focus groups. First, patients don't know what they don't know. In many instances, patients don't know that options exist. So when you combine this with the misconception that a large number of healthcare professionals hold, that patients aren't actually interested in participating in their healthcare decision-making, patients may not learn that options exist unless they do their own search for information. Moreover, even when a patient searches for information on their own, they're generally not likely to speak out during their healthcare visit for fear of insulting their provider and being considered that difficult patient. The fact is, however, that a growing body of evidence has shown that patients do want more information than they generally get from their providers about their options. Other very real barriers for implementing shared decision-making relate to health literacy and health numeracy issues. One way to surmount this challenge is to improve provider communication skills. Providers have to be able to effectively communicate options and risks to patients in order to successfully engage patients in the decision-making process. Other barriers cited in the literature and identified by health professionals include cultural as well as demographic variables. So how did these identified barriers drive the Share Approach program curriculum development? So first, regarding time, as we've seen, there's increasing evidence from many studies that shared decision-making doesn't have to take more time to implement than providing usual care. And in fact, as Dr. Lagar pointed out in her study in 2013, that training on shared decision-making should actually emphasize this point. So this is one element that was built into the Share Approach training. In addition, the Share training includes a video case example of a patient-provider interaction with and without shared decision-making. One point of the video is to show that implementing shared decision-making can occur by simply making subtle changes in the interaction with the patient, and it doesn't have to actually take more time. The other key facilitator to address time is that the training is intended for interdisciplinary teams, so that implementation of shared decision-making leverages the entire healthcare team, not just that treating clinician. Another design element was incorporated to address the "we already do it" barrier. Again, the video aims to show what shared decision-making really looks like. And this is not a simple barrier to overcome. Providers have been given an opportunity to see what shared decision-making actually looks like and the key elements that must be present for shared decision-making intervention to occur. The first module of our training walks participants through each step of the shared decision-making process and defines the key elements that must be present for true shared decision-making to occur. To address the belief that patients don't actually want to be involved, the SHARE training discusses the research that shows that this simply is not true. Moreover, the SHARE approach calls for an explicit invitation for patients and/or their family members. This is critical given that patients may not know that there's a decision to be made. To address the lack of organization support, the training includes a module on how to go about implementing shared decision-making in practice. And the key component of the steps to implement includes obtaining leadership buy-in. Additionally, one of the informational tools was developed to assist interested health professionals gain leadership support. Another key barrier noted is that health professionals don't really know how to use PCOR decision resources in shared decision-making, nor do they know where to access good quality evidence-based resources. So the training provides a module on what PCOR is, where to find it, and good patient and clinician resources from AHRQ. It also covers how to find and assess other non-AHRQ patient decision aids. To address the general lack of shared decision-making know-how, as we mentioned before, the training program also includes ongoing webinars, a learning network, and technical assistance. We knew a one-day training program wouldn't really be enough to get folks to implement their own shared decision-making programs. And so in our project design, we also included additional support for our trainees with, as I mentioned, the webinars, technical assistance in implementing their own training sessions, and the learning network. We envisioned a network of shared decision-making champions learning about shared decision-making, sharing it with others at their own organizations, and then sharing their experiences with us and other trainees so we could all learn from one another. We've also included features to address patient barriers. As we mentioned, some patients don't realize that they have a role in the decision-making process. The SHARE approach framework includes an explicit invitation from the provider to participate in decision-making. We also included a communication module that addresses health literacy, working with medical interpreters, cultural competency strategies, health numeracy, and the use of teach-back to ensure understanding. We also address demographic variables in an implementation module. And here we use multiple examples of how this shared decision-making can be implemented in the practice setting, including a variety of ways to deliver decision aids. So based on the formative research that we did for this project, we created a comprehensive collection of training resources that include, again, the Train the Trainer workshop curriculum and modules. To support the training, we have 9 informational tools, and those tools are short brochures that explain many of the steps in the modules and also have links to other evidence-based resources. We also have a video, a screensaver, and a poster that shows the steps of the SHARE approach. And on our website, we also link to other AHRQ resources that support or are related to shared decision-making. So here is our SHARE approach. It revolves around the implementation of a 5-step process that spells out SHARE to help you remember the steps. So the first step is to seek your patient's participation. Step 2 is to help your patient explore and compare treatment options. Step 3 is to assess your patient's values and preferences. Step 4 is to reach a decision with your patient. And step 5 is to evaluate your patient's decision. And the SHARE approach, it synthesizes the essential elements of shared decision-making identified in a systematic review of the literature by McCool and Klayman, published in 2006. and includes exploring and comparing benefits, harms, and risks of each healthcare option through meaningful dialogue about what matters most to the patient. So the SHARE approach is presented in a free one-day train-the-trainer workshop accredited for 10 types of clinicians to encourage integrated care teams to engage patients in shared decision-making. The SHARE approach workshop was designed to address the unmet needs of clinicians that we identified in the formative research phase for communication skills to facilitate shared decision-making and understanding how to use evidence-based patient information tools. The workshop is presented in 5 modules that address 1, the basic steps to shared decision-making, 2, the use of patient-centered outcomes research or PCOR decision aids to help patients understand their options, 3, communication skills to overcome common barriers to shared decision-making, such as low health literacy, low health numeracy, and cultural issues. 4 is implementing shared decision-making as a team, and 5, how to train others. The modular approach can be modified from a single-day event to a series of shorter events that can better fit busy clinician schedules. And to enhance the participant learning and recall, the curriculum employs effective hands-on adult education techniques, including small group discussion, role-playing, case studies, use of short videos, and large group discussion. As I mentioned before, we also have ongoing support from AHRQ. We know that, like I said, a one-time training, no matter how well executed, is insufficient to establish shared decision-making as an element of usual care and practice. And I mentioned all of these before, that we have these web conferences. This is our 2nd web conference this year. Our next webinar will be in July on examples of shared decision-making implementation. So keep an eye out for our announcement on that webinar coming soon. And also coming soon will be our learning network for participants who are currently and who have already participated in our workshops and will be participating in the future. So you can learn more about all of our resources and find links to specific resources at AHRQ's Share Approach website at www.ahrq.gov/sharedecisionmaking. And you can also find out more about the effective healthcare program materials that I described, including the patient research summaries and clinician research summaries that can be used as decision aids, as well as some interactive decision aids on the Effective Healthcare Program website, and that's at effectivehealthcare.arc.gov. And as I mentioned before, we are sponsoring 10 Share Approach workshops across the country this year, and you can find out more about those free workshops, including how to register on that Share Approach webpage. So here are the citations for all of the work cited in my presentation today. And here is my email address, as well as the email address to the Share Approach. And I just want to say thank you again for joining us today.
Thank you, Dr. Fournier. And with that, we've concluded our formal presentations for today's webinar. We will now use the remaining time to address questions from the audience. But before we do that, please take a moment to jot down the link on this slide if you are interested in receiving continuing education credits for this activity. So on the slide you see now, this is a link you should visit if you're interested in receiving continuing education credit. Now, this information will also be emailed to all the participants on this webinar. So we'll take a moment for you to copy that down, but it will also be emailed to you. So I think with that, we'll move on to some questions from you all. We've already been getting those questions in, so please keep them coming. As you were told earlier in the webinar, please use the Q&A panel that you see on this slide and on your screen to send us your questions. Please direct the questions to all panelists so that we can appropriately address them. And also, please feel free to send your questions to us if we don't have time in the remaining webinar. You can send your questions to share@ahrq.hhs.gov. And you see that email address on the bottom of the slide there. So now we're going to start off this question and answer period with a question for Dr. Lagar, and also part of this is for Dr. Friedberg as well. And there was a lot of talk about eliciting information from the patient, and this question has to do, are there key patient value preferences? Are there key patient value preferences that should be elicited from the patient? And can you share advice or strategies or approaches for effectively eliciting patients' values and goals? And then the other part of that is, are there certain values that providers actually have trouble aligning with? So, Dr. Lagar, if you can take that initial question, and then also Dr. Friedberg, please add in as well.
Okay, thank you for the question. So the work we've done, and we've worked a lot with the Ottawa Decision Support Framework. So I will send a link to the Ottawa Decision Support Group website because they, in their, I'll call it a generic patient decision aid. So somebody asked another question. The decision aid is actually a tool. There is international aspect to it. I mean, an international definition, the International Patient Decision Aid Standard of Patient Decision Aid. So it's a tool. So decision aid is a tool. And in the Ottawa Decision Aid that is generic, there is a nice way to actually tackle preferences and what's important for patients, because in fact, it's driven by the type of decision or the decision point you're engaging with the patient with. So I will please send to the organizer of this webinar the hyperlink to the patient decision aid from the Ottawa group that we call the generic patient decision aid, and you will see they have a nice section, very clear, very easy to use, so you can help your patient, or as a patient, you can help yourself identify what's important to you in relationship with a specific decision point and the options that are at stake.
Great, thank you. Dr. Friedberg, anything to add to that?
Just a couple of points to emphasize from what Dr. Lagar mentioned. First, the values and preferences are going to depend on the nature of the decision being considered. So there might be a different set of values and preferences concerning cancer screening versus a discrete surgical procedure like a hip or a knee replacement, or other options other than surgery. And the other thing about this is, and this was expressed to us by a number of the clinicians who are participating in this shared decision-making trial that we evaluated, you can catch a patient flat-footed pretty easily. People don't necessarily have a preformed set of values and preferences that they can just apply quickly to a given medical decision that they may not have considered previously. Like, a lot of patients may not realize there's more than one option for colorectal cancer, or that actually having no colorectal cancer screening is a perfectly valid option depending on their values and preferences, but they need some time to think those things over and often discuss them with their families. So there does need to be a period of time for mulling and letting these ideas incubate before a decision is reached in an optimal situation.
Great, thank you. Here's another question that really has to do with bias and how a provider views patients. And I think this question can be, again, for both Dr. Friedberg and Dr. Lagar. The question is if there's any evidence of greater conscious or unconscious bias influencing providers' assumptions regarding the ability to participate in shared decision-making, especially on the part of patients who are members of vulnerable populations, such as immigrants.
some of the qualitative work when you review barriers perceived by providers to engage their patient in shared decision-making actually refer to this aspect, where they have a sense that providing care to vulnerable people, so that would include immigrants. Sometimes they don't have an easy way with their language. I certainly know a little bit about this. It's something that they have, providers as I believe is based on some characteristic, including cultural, socioeconomic, education. We've heard this in some of our work, actually. Not only have we read it in the literature, but we pick that up when we work with providers. They would have a sense that if someone has not achieved a high school degree or more, that they may not be capable to share decision and thus engage with exchanging information, as my colleagues were saying. Health literacy is at play here, certainly. So yes, there are evidence that there's some bias in which some of our provider will tap for actually thinking that they will not be able to engage their patient because they may not have enough education or training in the language, etc. Unfortunately, and this is a message to get actually from the Joseph William review, as well as the work we've done, and I've heard it from my two other colleagues during the presentation, is this is something needed from our providers to actually pay attention and use strategy to engage these people, because this is actually where you may actually get the most gain.
Great, thank you. Anyone else?
Just one thing to add on this idea, especially regarding populations that may not speak the same language as the primary care provider. It may be necessary. We talked a little bit about attending to the training of clinicians, but in training medical interpreters may also be a good idea around shared decision-making, insofar as some medical interpreters have been trained already to sort of do some convincing of patients towards a given decision. This might seem a little bit foreign to switch gears and then be asked to present things more neutrally.
Mm-hmm. Very important.
Sorry, I would like to highlight what my colleague has just said. I think it's a very, very, very good suggestion to think of training medical interpreter to help into the process with those who don't have the same language as a provider. It's an excellent suggestion.
Yes, I agree. Very important point. Just a follow-up question along these same lines. Is there any evidence of differences in shared decision-making, especially for women or along gender lines? Anybody want to comment on that?
I can tackle it a little bit indirectly. We haven't seen, I don't remember having seen anything different in terms of a third observer capturing what's happening during a consultation based on the gender. However, what we've seen in doing some statistic review or revisiting some of our data sets is it seems that men experience more decisional conflict than women when actually facing difficult decisions. We haven't yet published this. It's a paper that's been submitted, but we hypothesize that maybe women actually have more a reason to have encounters with the healthcare system because of their relationship with the pregnancies and gynecological medical history. So that, as far as we've went into systematically reviewing some of the literature and revisiting some of our database, is men experience more not being comfortable with decision than women. But we do not have a valid or objective measure of how the consultation is happening or what's going on during the consultation.
Thank you. Very helpful. A question for Dr. Fournier. Are there any evaluation results yet from the SHARE training? No, you're just getting started, but there is a question about results from the actual SHARE training.
We don't have any formal results yet, as our evaluation is ongoing, and we have only done about half of our trainings for this year, and so we're going to continue to evaluate the training over time. So we'll be following up with our training participants with a 6-month survey, and then I think also a 1-year survey, but I can't remember exactly for sure. And so we'll be following up with them over time to see how they're implementing their workshops. We anticipate that we just started doing our workshops in January, and so we anticipate there will be some sort of startup time, if you will, for others to implement the training themselves, bring it to their organization, train others, and then actually to implement what they've learned into practice to see any results. But we are generally getting very positive feedback from the workshops. Folks are very excited about it. We have organizations who are very interested in the training because they're either already implementing some form of shared decision making and want additional training for their staff, or they have plans to implement shared decision making and are preparing to do so. So it's at this point, it's probably more on a case study type of basis, but the early indicators are that folks are very interested in this topic and want to learn more and are recognizing that shared decision making is important. But we don't have any real evaluation to be able to speak to at this point.
Great, thank you. And here's another question, and this may be something that's answered in your workshops, and for Dr. Fournier or any of the other panelists. There's a question if there is actually a template that people can use to design their own shared decision-making aids for those decisions for which a aid is not actually yet published. Dr. Fournier or Dr. Friedberg?
This is Elena. We don't necessarily address any templates from making your own, decision aids, but we do link to the IPDAS criteria, those and other guides such as the PMAT. I can't remember exactly what that stands for. It's an assessment tool for educational, I think it's patient education materials assessment tool that helps determine if the tools that you're using meet health literacy standards and will be effective for educating patients. So we provide links to those resources that can help in creating patient decision aids.
Yeah. I would like again maybe to emphasize, and there's no commercial relationship here, but again, the Ottawa group offers on their website, and it's you can just get it, for free and print it out. It's a Ottawa decision guide for any decision. So it's basically the skeleton, and you can actually populate it with a specific decision point, specific information, evidence, what could be discussed with the patient. And actually, patient can just Google right now if there's patient on the call, and they can just Google decision aid. They'll probably get on the Ottawa website and have the generic decision aid. So we often actually use this one when we do not have one that is specific and actually produced.
Great, thank you. Here's a question that I think is for Dr. Friedberg, and this is about HEDIS measures also needing to be adapted to take into account shared decision-making, particularly regarding palliative care. So I wonder if you have any comments about that, about how those measures need to be adapted and paying a special attention to palliative care.
Sure. So I'm not. I may not be familiar with the exact measure that the question refers to, but just as a general point, I think this raises a big issue, which is that a number of quality measures that are based on process performance, and I'm not picking on HEDIS in particular here, that may say, well, you get credit if a colorectal cancer screen was done and no credit if one was not done. The same can be true for certain measures of breast cancer screening where they're encouraging mammograms, for example. It's certainly, if you're doing shared decision-making, the right number of patients to receive those services is not going to be 100%. Under shared decision-making, the percentage is going to be somewhat less. And yet, depending on how those measures are deployed, providers might feel like they need to get to 100%. So it's not necessarily a defect of the measure so much as potentially a defect of its application, where it's important to have an escape clause where if you've done shared decision-making and a patient has made a shared decision not to go ahead and have that screening service, you should get full credit. There's no reason that should be penalized in any way, and you certainly wouldn't want to have an incentive that is perceived as penalizing physicians for non-performance of a service that a patient does not want.
Great, thank you. And here's another question for you, Dr. Friedberg. Just about measuring and distribution of decision aids is one small piece of evaluating actual shared decision-making in an organization. This question is specifically about what feasible methods do you suggest for actually measuring if shared decision-making is occurring in a practice and if it's high quality?
Yeah, that's a great question. And I think this is a pretty open area. Mm-hmm. I think a lot of this you can get from asking good questions to patients, actually. And you'd have to be careful about how you do this. You want to make sure you're capturing the right patient population at the right time to then report on the occurrence or non-occurrence of the conversations in which shared decision-making should be occurring. And, if the patients are giving you results that are inconsistent with a good decision conversation occurring, I would believe the patients on this, because even if you had a recording and you say, well, yes, they addressed such and such and such, these three things that we think are important. If the patient didn't absorb that information, it failed. The process did not work. So I would sort of go with the patient as the gold standard here.
That makes sense. Here's a question regarding the concern that shared decision-making takes a lot of extra time. And Dr. Lagar, I know you talked about that in your presentation. And this question has to do with hoping that the shared training, that this, takes into consideration this concern that providers have about shared decision-making taking extra time. And has there been work on wording and the dialogue between the patient and the provider to really address that concern? So Dr. Lagar, we'll start with you on this.
If I understand well, the participant is asking, is there a way of wording the consultation exchange so there's less word use? Is that what I
think it might be both. It's kind of addressing this overriding concern that providers have that it's taking too much time. And has there been work on making that dialogue, I guess, as efficient as possible? I think that's what the question is asking.
So very rapidly, I cannot think of a very specific study on this. I apologize for that. I just want to flag that our Cochrane review, so there is the the Cochrane-Stacey review on decision aid and our Cochrane review on intervention to implement decision-making, where there are 39 trials. We had at least a few trials that had also a similar finding as the Stacey one, where there is no robust evidence that when you effectively implement decision-making, that the consultation time will be longer. So one of the hypotheses for having done such some of these trials is the content of the consultation is reworked or re-engineered, I might say so. So it's like the content of the consultation is not exactly the same.
Great, thank you. And here's another question interesting about time that I'll direct to you, Dr. Friedberg, or any of the panelists. So under conditions where time is limited to make an emergent medical decision, how do you all recommend achieving shared decision-making, such as a stroke patient or some patient ending up in the emergency department 2 hours, after a stroke and, 10 minutes to decide something? Any thoughts on how you apply shared decision-making in those circumstances? Dr. Friedberg?
Yeah, that's a great question. If it's an emergency, or if, as in the case of a patient having a stroke, you have reason to believe that the patient is not in a position to be making a decision in his or her own best interests, it's just not going to be feasible to be doing the kind of shared decision-making that that would use a decision aid and have all this time for consideration and talking with multiple parties and so forth. So I think you do have to be a little choosy about where the decision where you're going to invest time and considerable resources in developing a shared decision-making apparatus. It may not be in those emergency situations.
Yes, that makes sense. Here's a question about how can the AHRQ or decision aids be integrated into clinical information systems, particularly electronic health records, to address some of the system-level barriers that Dr. Lagarde noted. So to both of you, Dr. Lagarde and Dr. Friedberg, this issue of how can electronic health records really support the performance of shared decision-making?
My understanding, because I haven't worked with the computerized decision aid yet, but my understanding, as my colleague said, and I will pass him I will let him answer, is that it will act as a prompt, making sure that the consultation is the clinician is taking. Being made aware that there is a decision aid that could be used for this situation. I see it as a prompt. I'll let you now, Mark, answer this.
Yeah. So there's the part of the electronic record that may prescribe the decision aid through a prompt to the provider or to the patient through a patient portal. You can certainly envision it working that way as well, or being even on demand, depending on the nature of the decision. Having that, there's lots of ways this could work out. It can be streaming, for example, through a patient portal, which then can verify that yes, the whole content has streamed, so the provider knows that it's been viewed, or at least it's been streamed to the patient's computer at home. But I think more broadly, there are some technical challenges that the entire health information technology industry is really wrestling with right now, and that has to do with integration of different EHRs with each other, and also with add-on products like decision aids. They don't talk to each other very well right now, and it's unlikely that there's going to be, at least with current technology, a decision aid technology that integrates with Epic and Cerner and Allscripts and Athena and all the different EHRs that are out there right now. So until we have pretty good interoperability between EHRs, it's unlikely, I think, that we're going to have sort of a uniform decision aid technology across these EHRs either. One other point that came up in our study regarding EHRs not having to do with the decision aids was just the ability to track patients through a sequence of processes over time, from the recognition of the decision opportunity to the use of the decision aid to the performance of the decision conversation, and then the post-decision aid conversation to the delivery of care. Right now, EHRs are very much still a replacement of paper charts and don't necessarily have that longitudinal view. To the extent that can be developed and be user-friendly, I think it'll really make a big difference in the performance of shared decision-making.
Thank you. Dr. Fournier, a question for you. Can you talk a little bit more about who should attend the Share Approach workshops? Is there a preferred provider or person to attend the Train the Trainer workshop and bring it back to the rest of the organization?
Thank you. That's a great question. So we have, as I mentioned, we have accredited the workshop for 10 different types of clinicians. So MDs, PAs, nurses, nurse practitioners, pharmacists, health educators, case study managers, et cetera. And so a variety of clinicians can come. I guess the ones that we're looking for to come to our primary workshops, those 10 that we're actually sponsoring, are folks that have the ability or have the desire to go back and train others. And then the secondary training is also accredited for those same types of providers. So they can bring this back, and their participants can go online, view an enduring module online, complete a little test, and get their certificate as well. So there's a big opportunity for folks to take it, but I think ones that we're hoping will come to the primary ones are the ones that really have, like I said, the ability to bring it back and bring it to others. So, and you don't necessarily need prior experience in training, because we have pretty much a training script, and we give you all the materials that you need to do this. But it helps to have some leadership buy-in, some resources to be able to implement those trainings on your own or with other teams. Also encourage having a couple of people from an organization to come, so that they can either tag team or work together to implement the training in their organization. So those are some considerations. We actually have a readiness assessment on our website that just says, take a look at that, read through the questions, and see how those pertain to you and whether or not you're ready to take the training and bring it back to others. And we're hoping in the future, in the near future, to actually have sort of an organizational readiness assessment as well that addresses whether organizations are ready to bring this training to their sites to implement it further.
Wonderful. Thank you. And I know if people have additional questions, they can send their emails to the share@ahrq.hhs.gov if you have additional questions about the workshop. We are getting so many great questions. I think we have time for about one more. So thank you for your great questions, and I apologize we can't get to them all. Here's one about the challenges with shared decision-making tools. One of the challenges is keeping them up to date as evidence changes. So wondering, how can that challenge be handled? How can we make sure these shared decision-making tools are relying on the latest evidence? Dr. Lagarde, do you want to start with that, and then Dr. Friedberg?
This is a very good question. I'm not sure that there is as good an answer to this, as evidence is a very dynamic field. Definitively, if you can attach your production of decision aid or decision support tool with a group that has the mandate actually to keep evidence at the center of their job, I guess that would be the best strategy. So to try to link a group that is dedicated to updating evidence with a group that maybe has more ease to produce decision aid would be the excellent strategy.
And
Dr. Friedberg, anything to add to that as we close out?
Yeah, just briefly, I think this speaks to the it's a little bit of a cautionary note on developing your own decision aid. A decision aid in part is like a review article, but it's even more challenging than writing one for a clinical or scientific audience because of making sure it's at the right level of literacy for a broader population. May even have a component for patients with very limited literacy, like a video. So keeping that kind of a tool up to date is challenging and time and resource intensive, and might be a good argument for relying on firms and foundations and universities that have really devoted a large part of their mission to doing this.
Great. Thank you very much. I think we are officially out of time. So I think we do need to close this off, and I really apologize that we can't get to all your great questions. So would encourage you to send them in to the email that you see at the bottom of the slide there. And we appreciate that all of you were able to attend the webinar today. And don't forget to apply for your continuing education credit, and to also register for a workshop if there's one in your area that you're interested in attending. So with that, I think we'll close out the webinar.